Welcome to the deep dive. We take complex stuff and, well, make it make sense. Today, we're going deep into a really tricky area, pelvic anatomy, specifically around the rectum. And it's not just about names, it's about why, tiny details matter so much for surgery, for outcomes.
Yeah.
We've dug into sources like pelvic anatomy and rectal surgery, key concepts and planes to kind of give you the fast track. Our mission, navigate this landscape, find the key layers, the landmarks, and hopefully give you some aha moments about all this terminology.
Yeah, and what's really striking is how, these anatomical terms, they sound abstract, right? But they become incredibly real, incredibly critical when you're talking about surgical results and, well, someone's actual well-being. It's not just for the surgeons listening. It's useful for anyone needing to get a handle on this field quickly. Professional need, or even just curiosity.
Absolutely. So let's try and visualize it, like we're peeling an onion, maybe. From the inside out. We start right at the rectal wall itself. That's the mucosa, submucosa, muscularis. These are the wall layers proper, not the fascia we're about to get into. Okay, so moving just outside that wall, what's the very first distinct layer a surgeon hits? The first wrapper.
Right. That's where you find the fascia propria of the rectum. Think of it like the rectum's own thin, shiny, kind of white capsule. It's the innermost visceral fascia layer. Sometimes people call it the mesorectal fascia.
Yeah.
And it directly wraps around the mesorectum, that fatty tissue bundle with lymph nodes and vessels. That's your immediate boundary.
Okay, the shiny capsule. And right outside that, we get to a layer with a really memorable name, the areolar plane, or the holy plane. Why so holy? What's so special about that one for surgeons?
It is a great name, isn't it? It gets called holy because it's an avascular surgical dissection plane, meaning it's a zone of loose connective tissue, almost a natural separation line, where there aren't many blood vessels. It sits perfectly between that fascia propria we just mentioned and the next layer out, the parietal fascia. And its significance is huge because it's the plane surgeons actively, use in things like TME, total mesorectal excision, because it allows for a cleaner cut, safer dissection, less bleeding. It really is a bit of a holy grail for getting good outcomes.
That's definitely an aha moment right there.
Yeah.
Okay, so moving outwards again, past this holy plane.
Yeah.
What's next in the stack?
Next layer out is the parietal pelvic fascia. So while the fascia propria was visceral covering the organ, this parietal fascia covers the pelvic walls. Backwards, it's the presacral fascia.
Good.
Sideways, it covers muscles like obturator, internus, and piriformis. That's the pelvic sidewall fascia. And critically, important stuff lies just outside this layer. Think hypogastric nerves, the pelvic plexus. Very important structures are right there.
Got it. And the final layer in this foundational set, the sort of outermost framework.
That would be the endopelvic fascia. This one's a bit thicker, more investing. It provides the main connective tissue scaffolding for the whole area. It's the architectural backbone, really. And it gives rise to these key ligament-like thickenings, like the lateral ligament of the rectum, uterosacral ligament, cardinal ligament, and also a really important one we need to talk more about, Waldeyer's fascia.
So putting it together, it sounds like it's not just what's there, but understanding which layers are safe highways and which are, danger zones. Getting these layers right, especially that holy plane, seems absolutely fundamental for clean surgery, good margins, fewer complications, particularly in cancer surgery.
Exactly right. Missing a plane or not identifying it properly, that can lead straight to serious problems. It's all about respecting the body's natural design to get the best result for the patient.
That really drives the point home. And you mentioned those ligamentous condensations.
Yeah.
Let's zoom in on one you said was really critical, Waldeyer's fascia, also called the rectosacral fascia. Sounds important, almost like it's guarding something. What's its deal, its origin?
Yeah, Waldeyer's is fascinating. It's a thick band, a condensation of the presacral fascia. Remember, that's the parietal fascia lining the back wall. And this is key. It's not derived from the visceral tissues around the rectum itself. It actually comes off the sacrum, usually S2 to S4 level. And then it inserts into the back of the rectum, behind the mesorectum. It basically acts like a kind of suspensory ligament, and it usually divides that presacral space. Because it's parietal in origin, that dictates how you have to handle it surgically. It's fibrous tissue, often has presacral veins and autonomic nerves crossing it. So, yeah, tricky spot.
Given that anatomy, how clinically important is it during surgery, like in TME?
Oh, incredibly important. During TME, you absolutely must divide this fascia sharply with scissors or energy device, not blunt dissection. If you don't recognize it or you handle it wrong, you risk really troublesome bleeding from those presacral veins that can be hard to stop. Or, equally bad, you could injure the hypogastric nerves nearby. It's a definite landmark, usually pops up around 4 to 5 centimeters of the anal verge. It signals a specific point in the dissection.
Okay, makes sense. Beyond these specific structures, how do surgeons use actual measurements inside the pelvis for planning? Are there like average distances that help?
Oh, definitely. We look closely at the, quote, distance between the peritoneal reflection of the rectum and the pelvic floor. These averages are really helpful guides. So, for instance, in men, that anterior peritoneal reflection, the bottom of the rectovesical pouch is usually about 7 to 9 centimeters from the anal verge. The pelvic floor itself is lower, maybe 3 to 4 centimeters. So that leaves a gap of what, roughly 4 to 6 centimeters between the reflection and the floor down there. In women, the anterior reflection, the pouch of Douglas or rectuterine pouch, sits a bit lower, maybe 5 to 7 centimeters from the anal verge. Pelvic floor similar, 3 to 4 centimeters. And posteriorly, in both men and women, that reflection point is higher up, more like 10 to 12 centimeters from the anal verge.
And why are those specific numbers so important? What do they tell the surgeon?
They're really vital for planning the TME. They help figure out if a tumor is intraperitoneal above the reflection or extraperitoneal below it. That changes the whole approach. And maybe most critically, these distances are key when deciding if a sphincter-saving approach is possible. Can you preserve the anal sphincter, or is a permanent stoma necessary? It's fascinating how these, seemingly simple distances drive such complex decisions. It really shapes the surgery for each individual patient. It highlights that need for personalized planning.
Yeah, that perfectly leads into our next point, which is a bit of a paradox, actually. The sacral promontory,
Yeah.
often called the keystone for pelvic surgery. But you also hear it's where fusion fascia lies, making operating hard. So how can it be both? How can a keystone be so tough to handle?
That's a great question, and it really gets at the nuance here. The promontory is a keystone mainly for orientation, for strategy. It's the clear starting point for TME dissection. It marks where the sigmoid colon transitions to the rectum. It's a landmark for big vessels, like the inferior mesenteric artery. It helps the surgeon get oriented to the right planes, the fascial relationships, and helps identify those critical nerves and the boundary of the mesorectum. It's like, the "you are here" marker on the map.
Okay, so it's crucial for getting your bearings, but then comes the difficulty, that fusion fascia zone. Why is that so challenging?
Exactly. The challenge is right at the promontory, the visceral fascia, the fascia propria, and the parietal fascia kind of fused together. There isn't that nice, clean, vascular holy plane we talked about earlier. Not right there. Instead, you've got a mix of lateral ligaments coming in, nerves nearby, sometimes vessels like the middle rectal artery. So this means you need sharp dissection here. You can't just bluntly spread the tissues apart easily. It's a real risk zone. If you dissect poorly, you can damage the hypogastric nerves, leading to sexual or bladder problems. You could also hit the presacral venous plexus that causes really nasty, hard-to-control bleeding. Or you could just get into the wrong plane entirely, maybe drift too far forward towards the ureters.
Wow. So it guides the strategy, but demands extreme care and execution. Really makes you appreciate the skill involved. And that saying you mentioned, stray below the promontory without caution, you're dancing with the devil's veins. That really paints a picture. Okay, let's try and clear up something that often confuses people. We've mentioned fascia propria of the rectum, mesorectum, endopelvic fascia, visceral pelvic fascia. It sounds like a lot of potentially overlapping terms. Are these all just different names for the same thing? Or are they distinct structures that are just related? We need some clarity here.
You're right, it's a common point of confusion. The terms do overlap a bit, which doesn't help. Let's try breaking it down. Think of it like getting the specific address for the rectum within the pelvis.
Right.
Okay, first. Fascia propria of rectum. Remember that thin, shiny, visceral layer? It directly surrounds the mesorectum. It's the surgical capsule. And the holy plane for TME is just outside it. My memory pearl for this is your holy plane of rectal surgery. Stick close to that capsule. Second, mesorectum. Now, this isn't fascia itself. It's the actual package deal, the fat, lymph nodes, vessels, nerves for the rectum. And importantly, it's enclosed by the fascia propria. Think of it as the lymphatic office of the rectum. Third, visceral pelvic fascia. This is broader. It's an umbrella term for the fascia covering all the pelvic organs, bladder, uterus, rectum. So yes, the fascia propria of the rectum is part of this category, but the term visceral pelvic fascia itself isn't really a specific dissection plane. Maybe think protect the temple of pelvic organs and way forth. Endopelvic fascia. This is the big one, the overall connective tissue framework. It includes both parietal layers lining the walls and visceral layers covering the organs. And it's the endopelvic fascia that thickens up to form those important ligaments like the lateral ligaments and Waldeyer's fascia. It's the architectural backbone of the pelvis.
Okay, that helps a lot. So definitely not the same thing, but closely related, like nested layers or parts of a bigger system.
Yeah.
That clarification feels crucial for building that precise mental map needed for surgery. Right, with that map clearer, let's talk about the actual roads or dissection planes surgeons use. Each has its own landmarks, dangers, significance. What about the anterior plane down low?
Yeah, the anterior plane, especially low down near the rectovesical pouch. Landmarks are obviously the anterior rectum, the peritoneal reflection. The danger zones are pretty clear. The ureters, especially as they come close in males, and the bladder wall itself. Clinically, it's significant because low rectal cancers often involve this area, so you need real precision to avoid injuring the bladder or ureters.
And the posterior plane, especially up near the sacral promontory where we talked about that tricky fusion fascia.
Up there, landmarks are the sacral promontory itself, Waldeyer's fascia when you find it, the whole presacral space. And the danger zones are big ones. Those hypogastric nerves and that presacral venous plexus. Super critical plane for TME, but, like we said, difficult because of the fused fascia. Requires meticulous sharp dissection to avoid nerve damage or major bleeding.
Okay, then laterally. The lateral plane during mesorectal dissection.
Laterally, landmarks include the lateral rectal ligaments, the endopelvic fascia forming the sidewall, danger zones, the inferior hypogastric plexus, more nerves, potentially the middle rectal artery if it's present, and the lateral ligaments themselves can bleed if not handled carefully. This is often seen as the most, let's say, favorable plane for peeling the mesorectum away, but nerve preservation is absolutely key here to maintain function.
And lastly, the posterolateral plane around Waldeyer's fascia.
Posterolaterally, you're again dealing with Waldeyer's fascia, the promontory view. Danger zones are still those hypogastric nerves, also pelvic splunchnic nerves, and the pelvic sidewall structures. This plane gets used particularly in challenging posterior dissections, helping navigate those tighter spots while trying to protect everything vital. Each plane really does have its unique challenges, and it raises that constant question: how do surgeons consistently protect the really vulnerable critical things like nerves throughout all this?
That is the crucial question, and it leads us nicely to something surgeons talk about, a kind of sacred zone for nerve preservation.
Hmm.
The Holy Triangle. Sounds almost mythical, but it's a very real, very important anatomical area in surgery, right?
Absolutely real and absolutely vital. The Holy Triangle is a key anatomical concept, a landmark zone, really, for guiding safe dissection deep in the pelvis, especially for nerve-sparing TME. It's basically a triangular space defined by three crucial structures that you absolutely have to keep safe. The ureter forms the lateral side of the triangle. The vas deferens in men, or the round ligament uterine artery in women, forms the medial or anterior side, and the hypogastric nerve forms the posterior boundary.
So you have to respect all three sides of that triangle. What are the consequences if one gets damaged?
Exactly. Damage the ureter, you could get urine leaks, strictures, serious kidney problems down the line. The vas destructs itself isn't life critical, but in males, it's a fantastic landmark guiding you away from other vital stuff. But the real functional heavy hitter is the hypogastric nerve. It carries autonomic nerve fibers essential for bladder function and sexual function. Injure that, and patients can face significant long-term issues like impotence, problems with ejaculation, urinary retention, or incontinence. Huge quality of life impacts. So, staying safe means identifying the ureter early, often starting up at the pelvic brim and tracing it down, gently mobilizing the vas deferens or uterine artery, not just clamping blindly. And for the hypogastric nerves, stay medial to the ureter, stay lateral to the mesorectum. Look for that sort of glistening plane where they often run. Staying in the holy plane of TME is your best bet here. If you picture looking down into the pelvis, maybe laparoscopically, you see the ureter sweeping down laterally, the vas or uterine artery crossing over it more anteriorly, and the hypogastric nerves running down behind that, the space between those three. That's your no-fly zone. There's an old saying: respect the triangle, preserve the man. Of course we should add men or women, because the nerve plexus is critical for everyone.
That's a powerful visual and a stark reminder of what's truly at stake beyond just removing the cancer. So looking ahead, how are surgeons pushing the boundaries here? What are some of the more advanced or evolving concepts in this complex field?
Well, it's definitely dynamic. What's fascinating is how things keep evolving. Beyond standard TME using the holy plane, people are talking about ultra TME, or extended resections for riskier cancers, going into the postlevator space. We're also getting better at understanding those fascial fusion zones, maybe calling them mesofascial transition zones now. And high-resolution pelvic MRI is huge. Surgeons are learning to read pre-op MRI like a radiologist to spot potential threats to the margins, identify enlarged lateral lymph nodes, see where planes might be distorted by the tumor.
What about specific techniques or procedures?
Well, lateral pelvic lymph node dissection, LPL&D, that's becoming more standard, especially in Asia. For lower rectal cancers, if the MRI shows suspicious nodes, say bigger than 7 millimeter. Robotics is really refining how that's done. Robotic surgery in general for rectal cancer allows things like dual quadrant dissection, working from different angles, and arguably finer dissection, which helps with those nerve sparing goals in the deep pelvis. Even things like prehabilitation, pre op pelvic floor muscle training are gaining ground to potentially improve post op continence. Plus, there's a deeper dive into understanding how the levator ani muscles recover. And even the naming, the nomenclature, keeps getting refined. Recent research suggests maybe there are dual layers in the presacral fascia or in Dennin-Villiers fascia anteriorly. It's a constant push for more precision, better outcomes.
It's a lot to keep track of. To help everyone listening consolidate this, maybe we could build a kind of three-level mental architecture, sort of surgical mind map for quick recall and planning.
Yeah, that's a useful way to think about it. A framework. Level 1. 3D zones the pelvis as geography. Just visualize the pelvis like a box. 4 main faces: anterior, posterior, lateral, and the inferior zone or pelvic floor. Each zone has its specific structures and challenges. Level 2. Fascia and planes your surgical compass. With every move, every dissection step, you're constantly asking, am I inside the fascia propria? Generally safe but close. Am I between mesorectal and presacral fascia? That's the holy plane, the goal. Or am I hitting a fusion zone? Warning bells. That guides your path second by second. And level 3, functionally critical zones, nerves, and outcome. Remember, you're not just taking out cancer, you're trying to preserve function, so you're constantly aware. Lateral side, danger zone for hypergastric nerves. Posteriorly, risk of presacral veins bleeding. Anteriorly, Dennin-Villiers fascia, crucial for sexual urinary function. And the infralevator plane, where the huge decision about sphincter saving versus APR happens. This is your critical nerve map overlay, so putting it all together in a real case, your mental flow might be something like, okay, at the promontory fusion fascia here, need sharp dissection, stay lateral. Mid-rectum, now, there's the areolar plane, should be smoother sailing here. Getting down to the pelvic floor, okay, pause, reevaluate. Sphincter saving possible or APR needed. Dissecting laterally, check MRI again, any nodes needing LPL&D. Anterior dissection, identify that Dennin-Villiers bilayer carefully, protect those neurovascular bundles. It becomes a dynamic checklist.
That's an incredible synthesis. What a journey we've taken. From these almost microscopic fascial layers right up to advanced surgical concepts and this practical mind map. The level of detail, the precision needed, it's truly mind-boggling. We really hope this deep dive has brought some clarity and maybe appreciation for this incredibly complex field.
Absolutely. And I think the key is that knowledge is most powerful when it's really understood and can be applied thoughtfully. Critical thinking, looking at things from different angles, that's always essential, especially with complex information like this.
Well said. Thank you for joining us on the deep dive. And a final thought for you to take away. Just consider how these tiny, often invisible anatomical differences, these planes and nerves, how they can have such massive impacts on someone's actual life, their physical function, their quality of life afterwards. It really underscores how every millimeter matters inside the human body and the incredible expertise it takes to understand and work within these intricate maps. Keep asking questions, stay curious,